So yeah, I just wanted to say thank you everyone for making the time to join today, and to those of you who are watching later on the recording, thanks for making the time to do that as well. I'm just going to start with a really brief introduction to the NHS Benchmarking Network for those of you who aren't familiar with us, and then I'm going to hand over to Steve, who's going to talk through his work as part of the Churchill Fellowship. So those of you who don't know who we are, the NHS Benchmarking Network is a UK-wide, impartial member-led community of health and social care organisations, and our focus is to support organisations to harness the power of data to drive that meaningful change. And there's a few different ways that we do that. So we have our membership programme, which kind of sits at the core of our offer. And what that comprises is a number of collections that run annually, monthly or quarterly, and cover the full kind of acute, community and mental health and learning disability and autism services. And then alongside that, I'm just going to skip to this third one, we have the workforce programme, which actually will end this year, but has run for a number of years, and it works as a census for the workforce in the mental health sector, as well as those national clinical audits that you may well be familiar with. So that includes CVD Prevent, National Audit for Care at the End of Life, and the Learning Disability Improvement Standards. And all of those have slightly different funding arrangements and are funded kind of in partnership with HQIP or NHS England or the likes. And then finally, we offer a range of kind of solutions and products and services that sit alongside all of our data to help organisations make best use of that data that is available, both through our member programme and from those publicly available sources. In terms of the member programme, this just gives kind of an overview of those collections. So as you can see, we have the indicator programme of work, which covers these two national and acute indicators, bringing publicly available data, and then community and mental health, learning disability and autism indicators collect monthly and report quarterly. And is data provided by members. And then we have that kind of cross-sector overview of emergency care, managing frailty and virtual wards, alongside our acute offer, which is pharmacy and medicines optimization and outpatients. And then the full fleet of mental health collections, which includes learning disability specialist services and an mental health pharmacy pilot as well. The data that Steve will kind of touch on today comes from our two kind of flagship mental health collections, the adults and older people's mental health collection and the children and young people's mental health collection. And finally, we have those community services as well that are detailed here. I will share these slides with more information on the network, but if anyone's got any questions about any of that, then please feel free to get in touch with me, and I'm happy to answer any questions. And it is with much delight that I hand over now to Steve Watkins. Over to you, Steve.
Thanks, Joe. Welcome, everyone. I'm just going to go through that, what for me is quite a tortuous process of sharing my screen. But if you just bear with me, hopefully this will work and we can get underway. So hopefully that should now be there with everyone. Wonderful. Okay. So hello, everyone. Thanks for joining. Thanks, Joe, for that really helpful introduction about the work of the network. I just want to kick off really by thanking you all for joining, but also thanking the NHS Benchmarking Network for hosting today. I'm also really grateful for the Churchill Fellowship for sponsoring the research that I did on international eating disorder strategies. And I'll talk a bit more in a moment about my background and why I've undertaken this work. But thanks for joining. Hopefully we'll have a really productive next hour. So what we are going to cover today, there's a little bit of housekeeping as ever, a tiny bit of background on the Churchill Fellowship and the data sources. And then the first block is really about where we are with eating disorder services in the UK and the case for change and the case for a national strategy for eating disorders in the UK. The second block is really to introduce how national strategies are working in other countries. So I work with 3 countries, Australia, Sweden and New Zealand, who have introduced confident national strategies or guidelines for eating disorders, which are real game changers in terms of how people access and experience eating disorders care. And then I'm going to wrap up at the end just to do a sort of so what position on where we are because of the research and what might be happening next in the UK. And then hopefully we'll have at least 15 minutes, maybe 20 minutes for discussion at the end. So just the housekeeping up first, that the webinar is being recorded, as Joe said. and that recording will be shared afterwards, as will the slides. Please stay on mute during the webinar. There will be time for discussion at the end, and we should be able to unmute people for that, hopefully. Of course, you can make comments as we go in the chat, and I think there are 4 or 5 members of the network team here today, including some of my old colleagues who'll be able to respond to those questions. So the plan is to present learning from the Churchill Fellowship research. And just for info, I think we were expecting maybe 70 or 80 people potentially to join today or to access the recording immediately afterwards. And the audience comes from a really wide range of backgrounds. So we have people from 7 countries on the call today. They all share an interest in eating disorders. We have some good clinical representation from specialist care. We have representation from primary care, secondary care, also from the charity and third sectors, from service user and care organisations, from the research community. And of course, with this being an NHSBN event, we have a really good spread of people from the data and the BI community as well. So everyone's welcome. All your comments are valid, and I'll be really intrigued when we get to the chat, some of the prompts that the presentation has made, and hopefully we can have a really good discussion at the end. So thank you all for joining. So a little bit about the Churchill Fellowship for those of you who are new to it. The Churchill Fellowship is the UK's living national memoriam to Sir Winston Churchill. It was established 60 years ago in the year of his death. And it exists really to promote lifelong learning for people in the UK in terms of learning from overseas, in terms of international good practice, and then bringing that back to try and implement positive change within the UK. They have a really good track record in terms of sponsoring activities in mental health over the years, including children and young people's mental health, the experience of care leavers, and also lots of work on suicide prevention and community mental health services. But this is the first time they've sponsored a project on eating disorders, which of course I'm delighted about. A little bit more about me and why I became interested in this area. So I'm currently working as an associate non-exec director. So I'm board member at Lancashire and South Cumbria NHS Foundation Trust. I'm just starting my 4th year in that role. I'm also a member of the Royal College of Psychiatrists Working Group on Eating Disorders and an occasional advisor to the UK All-Party Parliamentary Group on Eating Disorders. The aim of the fellowship, of course, is to explore national strategies for eating disorders because we don't have one in the UK, and the benefits of those strategies. Just a little bit more about me for those of you who are meeting me for the first time today. For 26 years, I led the work programme of the NHS Benchmarking Network, and Joe introduced and gave a bit of background before I spoke. We always had a huge work programme on mental health services, and it was really valued by policy teams across the UK. And every year we would publish a huge annual stocktake of data which talked about how services were delivered, how they were accessed, how they were performing. And one of the things that always bothered me, despite working in a time of really positive change for mental health, where we had some huge advances in areas such as CYP mental health, NHS talking therapies, perinatal care, first episode psychosis care, was that eating disorders almost felt a bit like a forgotten specialty. We had some very, very low numbers of people who were able to access care, something like 25,000 people. I think it was during my last year of NHSBN. And there was a big gap with the sort of estimates that were made about morbidity and disease prevalence for eating disorders. So the reason I've advanced the fellowship is just this idea that there's a real opportunity here to learn from countries that do now have national strategies. There is a link just at the bottom of that slide to my detailed report if anyone hasn't seen it yet, and I would encourage you to access that if you find today's webinar helpful. So eating disorder morbidity is rising, and it's rising across the world. I think the story that we're seeing in the UK of really fast accelerating demand is not unique, and my research suggests that it's there really in all developed countries. if we're trying to put a position on UK eating disorder prevalence, the morbidity estimates, the historic one I always used to refer to was the BEAT estimate of 1.25 million people in the UK. That's it. That's against a population of around about 68 million people. It's a really well-researched and authoritative estimate, is the work from BEAT. However, it was published a few years ago, and I know that BEAT are now looking at this in terms of coming up with an amended and updated prevalence estimate. In 2019, NHS England published commissioning guidelines on eating disorders, which suggested a 6% lifetime prevalence rate, which would position lifetime prevalence at about 3 to 3.5 million people across the UK. And there was a really helpful report published just a few months ago, the National Audit of Eating Disorders, a comprehensive national mapping exercise, which suggested 7.5% prevalence. So whichever way we look at this, there's a substantial treatment gap. And I'll talk a bit more about the data about where we are in a second. This is an example of one of those NHSBN slides. All of this data is accessible on the NHSBN website, and you can really do a comprehensive drill down of where UK eating disorder services are. And if you're a service provider, you're placed within that range. So just for illustration, last year there were 31,000 referrals to adult eating disorder services. So when benchmarked to 100,000 adult population, that comes out about 115 patients per 100,000 population. So that's a percentage rate of 0.115%. So it's massively adrift of that 6% lifetime prevalence that was published by NHS England. It's something like 1 in 52 of people who may have the condition are referred to specialist care each year. So that's the extent of the treatment gap that we're talking about. And it's a treatment gap that I consider to be the largest in UK healthcare. Just to put another illustration of it, this chart shows community mental health team caseloads across England, across that full breadth of all services that are delivered in the community. So about 700,000 people at any one point on CMHT caseloads across England. If you look at the red slice of the pie, that's eating disorders, and they're just 1.7% of the total. So in terms of overall CMHT spread, eating disorders are currently a very small relative specialty compared to some of the other specialties. So the biggest one is generic district-based CMHT care. Old age services are quite big, and we're seeing a real advance now for services for people with ASD as well. What was interesting to me, though, if you look at the bright green pie, that's perinatal mental health services, they've grown by a factor of 5 within the last 8 years, and they benefited from being part of a national strategy. And the pink slice of the pie, that's first episode psychosis, they've also doubled in size due to a national strategy within England. So change is possible, and I'm a huge advocate for that change within eating disorders care. Of course, even though services are relatively small, people do still get ill. And one of the endpoints of that illness at the moment is that people will turn up in hospital, and they turn up in hospital in large numbers. So we have about 20,000 adults who experience CMHT-based eating disorder care each year, and about 14,000 young people across the UK. So that's 34,000 people in total. But we have 36,000 hospital admissions for eating disorders care. Only about 1,500 of those are to specialist eating disorder beds, and I'll talk about those in a second. So the majority, or 95% of admissions, are actually to general medical services in acute hospitals, whether that's for adult general medical care or for paediatric care. So for most people, their experience is not one of receiving specialist care, but it's one of receiving sort of urgent crisis care as a result of the lack of core infrastructure around community-based and primary care-based eating disorder care. And of course, this always costs the NHS as well. And my sort of high-level estimates of the value of this are about £250 million a year in avoidable care from overflow admissions into acute hospitals. This is the sort of summation of some of that NHSBN data now. And the way I've structured this is to show it against a stepped care pyramid. And I'll talk more about that stepped care model in a moment, because that's what is playing out in Australia, New Zealand, and Sweden. So the top of the pyramid, if we like, which is the specialist adult and adult eating disorder beds. We have CYP beds as well, but CYP are more likely to be admitted to a general CAMS unit. So 450 adult specialist eating disorder beds, about 60% of those are delivered by the NHS and about 40% by the independent sector. They process about 1,500 admissions a year, and they consume about half the total funding for the specialist eating disorders budget in England each year. So it's really a high acuity, late stage model of care, I would argue. Just to illustrate that, the average BMI at admission is about 14, which is much lower than it is in other countries. The average length of stay is 100 days, and the average cost per admission is about £100,000, which is more expensive than a heart-lung transplant costs the NHS. So there's something about the efficacy of the current model of inpatient care we have, which needs reviewing, I would argue. Daycare is a massive part of the step care model in other countries. We do have daycare in NHS, but we don't have it in a structured, managed way in all health systems. So for example, where I work in the NHS, there isn't any NHS provided daycare for 7.5 million people. There's a small and really quite good private clinic which operates and provides daycare, but for most people, their experience will be they cannot access daycare, and that's not unique to the NHS in the Northwest. It's there in many other regions as well. Intensive home care is largely unavailable. We do have, of course, those specialist community-based teams, both for adults and for young people there, and they're a really important part of the provision model, and they generally provide really excellent care. But then below that, if we're looking at that sort of level of care around early intervention, primary care, digital and talking therapies, there's a very, very limited response where primary care, I would argue, has a limited capability. People with eating disorders are excluded from NHS talking therapies, and there isn't a national digital care offer, although some individual provider collaboratives are now starting to pilot this locally. And then in terms of wider health promotion and prevention, I would argue, again, it's a very limited response around counter messaging, around all the stuff we see about body image, which just is all around us, of course. So that's the step care model as it applies in the UK at the moment. And I would argue that many of the fundamental steps of it don't exist. And there's a real opportunity to review how that ecosystem for eating disorders works in future. But, don't give up hope. There are countries that are pioneering different approaches and getting real benefits from national strategies. So I work with Australia, with Sweden, and with New Zealand. I met with governments in each country. I also met with providers, with service user and care organisations, and also with the research community in each country. The aim was to get a view of policy, but also service provision models, some of the innovations, and there was a special theme per country as well. So in Australia, to work with the National Clinical Standards Agency, the Inside Out Institute in New Zealand, to look at the experience of minority populations, particularly Maori, and then in Sweden to explore that really positive relationship with the research sector. So let's start out with that experience from other countries then. And one of the things that really struck me actually was the extent of political support, and political support is absolutely key for getting national strategies off the ground. So the chap on the left there, that's Anthony Albanese, who's the Australian Prime Minister. He's now in his second term as PM in Australia. And Australia launched their national eating disorder strategy as part of a wider mental health strategy with $1 billion worth of investment. But what was interesting for me is that eating disorder was the lead item within that national strategy. And Anthony Albanese really talks quite movingly about his own personal experience of a family friend who had a life-threatening eating disorder and how that stayed with him throughout his life, and therefore his wish to do that for Australians impacted by eating disorders. The chap in the middle is Minister Matt Ducey. He's the Minister for Mental Health in New Zealand. He also has a personal commitment to this. He has lived experience of mental health conditions, and in his launch of their national strategy in September 2025, he again talks about the need and the importance of putting service user and carer communities right at the centre of the strategy development and subsequent implementation phase. So it was terrific to see that political support in these countries, and it's also there in Sweden. Do you know what? There's quite a lot of it in the UK as well, but at the moment, it isn't coordinated, I would argue. The APPG does great work, but eating disorders didn't receive a single mention in the 10-year plan for health, which was published last year. So there's a bit of work to do in the UK, but there are some reasons for optimism in terms of the learning from other countries. So we'll start with Australia. Australia have a 10-year national eating disorder strategy, which was published 3 years ago. The work was led by the National Eating Disorders Collaboration, who are a terrific organisation led by a lady called Dr. Sarah Trobe. They're doing incredible work. What I didn't realise before arriving in Australia is actually there was a long list of eating disorder strategies at state level. So New South Wales has had a strategy for 10 years prior to the national strategy, so did Victoria, and Queensland also had a really positive sub-strategy for eating disorders. What I'm going to do is I'm just going to go through each of these squares because it will, in a nutshell, it will give you a sense of what's in the Australian National Strategy, which is a really comprehensive document. So Australia's population is 27 million. There's 1.1 million people in Australia impacted by eating disorders. One of my first meetings was with this man, a lovely man called Dr. Murray Wright. He's the chief psychiatrist for New South Wales. My opening question to him was, Murray, where did your strategy come from? And he just replied to me really quite bluntly, our eating disorder strategy was born out of necessity. Our hospitals were being overwhelmed by late-stage eating disorder patients presenting, and we needed to do better than that. And they came up with this mantra in Australia that eating disorders are everyone's business in all health and care systems. So rather than being seen as a niche specialist mental health condition, they're now seen as a common broad-based condition which people working in health and care need to be aware of. So the strategy is really a call to action and a roadmap of national standards. It's about an equitable, coordinated system of care, and its objectives are to reduce prevalence in future, to improve recovery outcomes and the quality of life for people impacted. There's a whole series of minimum standards defined in the national strategy and priority actions to deliver each year. And when I was there last year, they were working on 64 specific actions to deliver that year to move the strategy forward. A lot of those were around workforce development, and minimum standards, both for the specialist eating disorder workforce and also for the wider general workforce. And this comes with this vision of contributing to the process of one day finding a cure for eating disorders. So there's that moonshot, and we'll hear a bit more about moonshots at the end of the presentation. So Australia do have a full step system of care, and they're working at the moment to fill some gaps within that step system, but they've defined it in terms of prevention, identification, early response, initial response, treatment of different intensities, ongoing psychosocial and recovery support, and then a broad commitment to workforce development. I mentioned the political support a second ago, and that's also it also comes through in terms of the Medicare support that's available in Australia. So Australia runs two parallel systems, a free public healthcare system, but just over half the Australian population also have health insurance. And for people who have health insurance, they can claim up for eating disorder care at the level of 40 sessions of CBT and 20 sessions of dietitian support. So it's a really high level of funded reimbursed support from the federal government for people accessing through health insurance. Another really important point about Australia and also about New Zealand actually is that all medical admissions for eating disorders are managed by acute hospital MDTs. There are no specialist eating disorder beds in Australia or New Zealand. People who've heard me speak on this before will know that I am agnostic on this. Obviously, we do have specialist eating disorder beds in this country, and we also have a lot of overflow into acute hospital care. I don't have strong opinions either way about which the best model is, but apart from the fact that the model needs to work well, and I think at the moment in the UK it doesn't work well because we have this significant overflow into acute care. This is the strategy on a page. I'm just putting that there for you so you can access this one later, but this does feature in the National Eating Disorder Strategy for Australia. It's got those different levels of the step care system shown clearly within it. In my first week there, I attended the New South Wales State Strategy Steering Committee for Eating Disorders. I was really buzzed up by going to this meeting, and it really convinced me this point that eating disorders are everyone's business in the Australian healthcare system. It felt very different in truth from the many forums I've been to in the UK. So the meeting was chaired by a really senior servant from the Ministry of Health, and some of the other people there, just to give you an illustration of the fact it is now everyone's business in Australia. There were acute physicians. They were probably the dominant clinical group, actually, in terms of numbers. There were paediatricians, specialist nurses from acute hospitals, psychiatry. And by psychiatry, I mean there were CAM psychiatrists, there were lots of liaison psychiatrists, and also clinical psychologists. There's also representation from primary care, from local health districts who are the commissioning unit, like our CCGs, health boards, or ICBs, university and academic partners, delivery specialists, workforce development teams, eating disorder coordinators, I'll talk a bit more about in a moment, and really some great service use and care representation. So it was a really diverse forum. And for me, hearing the individuals talk of the day, what it stood for me was that this was a clinical network, actually. And it's a clinical network which went just out of eating disorders that we have in the UK being a niche mental health specialty. And I apologize for using terms like this, into a specialty which now much more broader base and had interest and contributions, really importantly, from many different disciplines. I tested this out really by going to a local health district in Hunter, New England Health District. So they're just up the coast from Sydney in a city called Newcastle. And New South Wales had obviously had its eating disorder strategy for many years, so eating disorders matter New South Wales. But guess what? This local health district also had its eating disorder strategy. So there's 3 levels of local district, statewide, and then national. We're all fully integrated. I mentioned earlier that the acute management is all through acute hospitals, through adult general medical care and paediatric care. And what struck me is there are 17 hospitals in this health district in Australia, and 16 of the 17 have got named designated wards for eating disorder patients where they're received and treated. And there was a really effective and large MDT which worked around these patients, involving medical staff, paediatric staff, mental health professionals in reaching, and also specialist nursing and therapist teams. There was also really active clinical networks in this LHD, as there are in all local health districts in Australia. So each local health district has a nominated lead eating disorder coordinator. They have a nominated lead eating disorder clinician and a lead dietitian. So you've got 3 people working intensively there to make that managed clinical network work. And eating disorders in this local health district was included in mandatory training. And they'd also succeeded in training 1,300 staff across the health district in specialist eating disorder pathways. So that the point about being everyone's business was really broadening out understanding and contributions. This is an illustration. So remember I said there are no specialist eating disorder units in Australia, but they do have what they call residential facilities, residential units, which are really rehab units. This is the one for New South Wales, which is also based in Hunter, New England. It's got 12 beds. It accommodates medically stable patients, either stepping up or stepping down. It costs £6 million to build, so it's really great value. And it has a large daycare facility operating alongside those rehab beds, as well as some outpatient services. I'm going to mention the Inside Out Institute now. They're the National Clinical Standards Agency for eating disorders across Australia. They're the organisation responsible for getting eating disorder coordinators and lead clinicians within all local health districts. Some of the initiatives they've led include a national GP hub for eating disorders. I'll talk about that in a second, and also about their e-therapies for binge eating disorder and bulimia nervosa. They also lead on national e-learning for eating disorders and upskilling the workforce, and they've trained 15,000 people on eating disorders care. This is one of the specialist initiatives that they're hosting through the Inside Out Institute. So I've just put a screen grab on the right-hand side of the page there. This is the National GP Hub, which is funded by the federal government, and it's endorsed by the Royal Australian College of GPs. So what's included within that? There's stuff around prevention and health promotion, screening, early intervention, diagnosis, assessment, treatment, medical management, also rehab and relapse prevention. So it's really putting tools and support and knowledge on that GP and practice nurse desktop so that they can receive and help diagnose people early, and also contribute to the ongoing management of those patients and their eating disorder. One of their other initiatives Inside Out is their national e-therapy system. This provides remote digital care for people with bulimia and binge eating disorder. It's free, it's evidence-based. It was initially funded as a pilot for New South Wales by the Ministry of Health, Department of Health and Aged Care. It allows self-referrals. It's a structured course of self-help CBT with goals and ability to challenge eating disorder thoughts and behaviours. The aim was to get 6,000 patients through this service in the first year in New South Wales, but after a few months of operation, the national federal government liked it so much that they've funded a national rollout across Australia, which is now well underway. So I'm quickly going to move on to New Zealand, actually, as the second of the three countries. So New Zealand, clinical networks in New Zealand are quite similar to Australia, and they do work quite collaboratively. There's just over 5 million people in New Zealand, 400,000 forecast lifetime prevalence. That's 7.8% of the New Zealand population. Like in Australia, management of eating disorders in terms of medical management is done in acute hospitals. I did go to a couple of hospitals, and so the home ward model was certainly working in Auckland when I visited both adult and children's hospitals, and there's an aspiration to extend that across the country. There are 0 specialist eating disorder beds, although there are 25 rehab beds, so reference to that Australian model again. And their CMHTs for eating disorders work on the basis of 4 specialist regional teams, so 3 in the North Island, 1 in the South Island. And they've developed a consultant liaise model where the eating disorder teams, they provide specialist care and they case manage, but they also train other healthcare professionals such as GPs and counsellors, primary healthcare nurses to provide care, and they support that through a telemedicine approach. So that extends the reach. But New Zealand, the number of people who access specialist care is really quite low. It's only about 2,000 people. So that actually positions them with lower access than we see in the UK. So there is a lot of unmet need, there's high acuity, and the government was really quite clear that there was a case here for a new national strategy. So these are the main points in the New Zealand national strategy, which was published in September. So it's about improving access to care. It's about developing the workforce, so that everyone's business thing in the middle there. And it's also about a full step care model of care, a full continuum of care. What struck me about New Zealand also was how culturally aware the national strategy is. Obviously, eating and issues around food can be culturally specific, and that's certainly recognised in New Zealand, where Maori, for example, would have a higher instance of bulimia and binge eating than European populations. So the strategy was launched in September 25. What really impressed me actually about the national government in New Zealand was that they entered this whole process of developing a strategy by saying, actually, there's no money available, but we still need to develop a strategy because it's the right thing to do in terms of clinical standards. It's the right thing to do in terms of patient experience. However, on the day of the strategy launch, they miracled up 20% additional funding for eating disorder services across the country. And that was really informed in some way by this fellowship and by the evidence that was collected from Australia, from the UK and from Sweden about how New Zealand fundamentally needed more capacity. The minority populations are specifically highlighted within the national strategy about groups of the population who need additional and more nuanced care. And it's recognising that there are morbidity differences between different population groups. And there's a really fantastic Maori eating disorder networks, which have been established for some years. And this term, Kawina, cultural advisors for Maori and Asian people, are employed within all of the eating disorder services within New Zealand to try and focus on those population groups' particular needs. I'm going to move on to Sweden now. Sweden are the country with probably the most complete of the step care models and certainly provide care to more people than any of the countries I visited, actually. So services are certainly more available than the UK. Sweden's national guidelines were published in 2024. They're very comprehensive. Sweden's population, 10.5 million, forecast prevalence, 300,000 people. All of the healthcare planning in Sweden is done on a very evidence-based basis through a series of consensus statements and guidelines. And just for illustration, in Sweden, all healthcare conditions are ranked on a scale of 1 to 10 in terms of severity. So 10 might be, say a pandemic, whereas anorexia nervosa was rated 9. So that gives you a view of the severity that anorexia is viewed within the Swedish healthcare system, and therefore the urgency of the need to act. Half of all CYP bed days are now anorexia nervosa within Sweden, and there's a recognition in the national strategy to expand anorexia care along with ARFID care to make it more resilient, as well as the need to make bulimia and binge eating disorder care more available, and particularly within primary care in terms of early intervention. So the National Board of Health and Welfare published the strategy in 2024, and it's really about a very intensive full-step care model, community-based services with specialist care, and then super specialist care available beyond that, with social care fully integrated into the model too. And this is the national strategy on a page. It's really quite difficult to get 700 and odd pages on a page. But some of the points I picked out for this, there are 4 big building blocks within the national strategy. The first is a point about improving access to care, of course. And so the strategy mentions the need to do better for kids with ARFID, the need to make services available in primary care, as I said, for bulimia and binge eating. And for anorexia patients, they should be able to receive reinforced care through offering specialist daycare services, for example. The second building block is about improving knowledge, both with decision makers who are commissioning and providing services, and also to make sure there are sufficient therapists and caregivers available within the care system. The third block is about adapting care to the individual. And some of the bullet points within this, so for example, comorbid conditions, evident in eating disorders, which we know are often very evident with people, they should be identified and treated alongside the core eating disorder. There should be several types of psychological therapy treatment available. Obviously, for adults, it would be CBTE, but there are additional therapeutic options available for patients as well. There should be focus on support to improve quality of life for patients and avoid deterioration for people with long-term anorexia, and that people should work multi-professionally around ARFID, and that's really referencing those different specialist care groups within children's care. Then the final block is really important, which is about relapse prevention and recovery care. That point there to build trust and avoid suffering, and 2 big themes there. One is that booster sessions are available for people if relapse is threatened, so that people don't need to deteriorate before and don't need to wait before they access care again. And the final point there is that primary care should consider responding in the same way as it does for anxiety and depression. Obviously, that's a great parallel for us there in the UK with some of the great services we have for anxiety and depression in primary care. I'm just going to talk about what I saw in Stockholm. I joined the Stockholm Centre for Eating Disorders, who are a wonderful organisation, for a couple of days, and I was so impressed by what I saw there. Just some metrics about the service. So they support 2.5 million people in the Stockholm region. 20,000 people are known to the clinic. So this is something here about upscaling of services. They treat 3,000 cases per year historically, with an aspiration to grow that to 4,500 this year. So the provision levels historically are about 2.5 times higher than we see in the UK. And this year that could grow to over 3 times the level. And there's really an intensive full step care service available. It's an all age service as well. So for Stockholm, there are 40 beds. The BMI admission average is 16, so it's much higher than we see in the UK. So intervention is earlier. There are also 80 or more daycare places always available. And I was really struck by this, that daycare is really the engine room of the specialist care service in Sweden. And every region, I visited 3 of the 5 specialist care services across Sweden. They all had daycare at scale, actually. So what I took from that is that for inpatient care to work properly and for community-based care to work properly, daycare is really the key enabler for that. They also offer outreach and home treatment, digital care I'll talk about in a second, and a really strong focus on relapse prevention. They have a great MDT of all the different disciplines, and it also includes physical healthcare therapists within that. 2 teams I want to give particular mention to, actually. One is the SEED team for severe and enduring eating disorders. We don't really have these teams in the UK. This has been established for over 10 years with a 100-patient caseload. It's generally focusing at patients who've had an eating disorder for 7 or more years, given that the average recovery for anorexia would be about 6 years. So an older cohort, average age 38, lots of comorbidities, but really intensive and goals focused therapeutic option with lots of different options available for patients who can access inpatient daycare and also intensive outpatient care. But that isn't the end of it in terms of the different levels of specialist care available within Sweden. So there's a level above that called NHV, National Highly Specialised Care. And this is for patients who have the highest acuity, most at risk of death, most at risk of severe deterioration. So for patients who've had 2 or more previous cycles of unsuccessful care. So they get a 12-week intensive care program with 12-month monitoring. And again, lots of different therapeutic options available. Sometimes this issue of novel therapies to break the chain of an eating disorder. And I love this term they use there, which is about the NHV service being a magic card to try and break that eating disorder cycle. Finally, from Sweden, there's the point here about the digital care office. This is long established. So again, it's something we should really be doing in the UK. Established since 2019, and they offer evidence-based first-line e-therapies for bulimia, for binge eating, and also for ARFID, for family support. Unlike Australia, this care is supervised, so care coordinators do an initial assessment with patients. They can also see patients' medical records, and they text or call patients as they go through that process of receiving the digital therapy. So they're regular check-ins. The outcomes are great, so 80% of patients report improved outcomes. And patients can also access this model in terms of relapse prevention. They've got this absolutely brilliant tool called DigiBooster, which is a relapse prevention tool, again, CBT based, with access to therapists as and when needed by patients. So there's a really strong commitment to relapse prevention within Sweden. So in conclusion, my main messages from on the left-hand side from the UK, really, there's really a substantial case for change in UK eating disorder services. Although services have improved for kids, there's a massive treatment gap for adult eating disorders, and the national strategy would offer a way out of this, a solution to try and bridge that treatment gap. We can see that the strategy is really delivering substantial benefits in Australia, New Zealand, and Sweden, even though that work is ongoing. And the current fiscal position with the government is no reason not to act. This should be a quality initiative. It doesn't have to cost any more money, but ignoring it because we have fiscal problems within UK society at the moment is not the way to go. And that final bullet there, eating disorders are common conditions and they should be everyone's business in all healthcare systems. I was really taken by some of the innovations I saw, and the ones that stood out to me most were the eating disorder coordinators and clinical networks in Australia, the digital therapies, which can absolutely reshape how people access care, and they're working really well in both Australia and Sweden. The support to primary care in Australia and Sweden, daycare at scale in Sweden, along with intensive outpatient services, workforce development, which was a key aspiration in all 3 countries, and in New Zealand, their ability to target cultural issues around health inequalities and minority populations. And of course, throughout this, lived experience was valued and it was evident at all levels of the care system. So this is my final slide, actually, and it's just my work from here. So I have been sharing this work throughout the process. So I've had regular meetings with national policy teams, NHS England. I met with the Scottish Government. I've attended many clinical reference groups. I spoke at the APPG report reference in Parliament back in January, and also at the RC Psych International Congress. And I've been doing a lot of local sessions with ICBs and trusts. So again, if this is of interest in your organisation, please let me know. The report was published in December, which was great. It's been shared with many countries, and there are some ongoing policy briefings. And there is a reason for optimism here now, actually, in the UK. In that a couple of weeks ago, there was a ministerial roundtable where the health minister, along with Adrian James, National Clinical Director for Mental Health for England, did commit actually to including eating disorders within the upcoming modern service framework for severe mental illness. So eating disorders will now feature within national guidelines within the NHS in England, which is absolutely terrific news and a great place to start what will hopefully be a fruitful and optimistic next stage. So I'm going to stop there, Danny, if I can stop. Sorry, Danny and Joe. I'm going to stop there. I hope that was okay with everyone, and I'm available for questions if people have any questions.
That was really super interesting, Steve, and it was interesting to see on your last slide there that you referenced that you've spoken with the Scottish Government about it, because we did a piece of work a couple of years ago about supporting the Scottish Government in measuring the implementation of their national specification on eating disorders that's come in. And I suppose it's just interesting to see that obviously the devolved governments within the UK have taken slightly different approaches. But yeah.
Thanks, Joe. I have a question from a very, very special person here, Zoe Morris, who well, can't speak highly enough of Zoe, who helped me for many years doing this work at NHS. Hi, Zoe. Hopefully you can speak and come in.
I do have a question. That was really interesting, as always. It's so soothing to hear you presenting again, Steve. I was just reflecting on what you'd said around the late stage presentations in Australia, having driven some of the change. And of course, we've had the access and waiting time standards for children and young people for a few years. We've only sort of recently mopped up adults through the more generic access and waiting time standard for community services. Did any of the countries you've visited sort of have expected standards around how rapid people would be able to access treatment, and how compliant are they? Because obviously we have the standards here, but I know as a provider we struggle to meet the standard, which kind of defeats the object a little bit of having that standard if we can't even always deliver to that.
Yeah, great question, Zoe. Do you know what? The English standard of 4 weeks for CYP to receive care is a brilliant standard, and we've got about 75% compliance at the moment, and it's a game changer, and it really has transformed how kids receive this care. Obviously, it's not so good for adults. I think the issue for adults is more about high thresholds rather than about waiting times. And waiting times seem to be about 8 weeks at the moment across the UK. But there are many, many anecdotes and stories. That's average waits of people who are waiting much longer than that, sometimes a year or over. Do you know what? The CYP 4-week standard is terrific, even internationally. The teams in Sweden actually have the best waiting time performance, and most people in Sweden would start care within a month. Because of Australia's private healthcare system, it's not as easy to measure, because many people would be referred and going basically into private healthcare for psychological therapy or dietetic support. So it's not as well recorded. I did speak with our good friend Grant Sarah, and he's on a mission to make sure all of this great content is recorded. And in New Zealand, people would wait around about 8 weeks as well. So we're not a fundamental international outlier there, but I think Sweden offers the best model, and I think they're really quite good. Waiting times are shaped by the fact they've got more capacity, probably 3 times the level of capacity we have in the UK. So thanks, sir. Anne, would you like to ask a question?
I think Tom was before me. I don't know.
Tom was. I'm so sorry, Tom. Tom, come on, Tom. You asked me a question.
Thanks, Anne. It's all right, Stephen. I mean, we've been talking a bit about kind of a strategy and the sort of political challenges with that. I want to actually pick up on the point that Joe made, which is, so would you classify what's happened in Scotland and indeed Wales as national strategies, in the sense they had these kind of large reviews and they came out with kind of clear recommendations which were largely accepted by government, but like New Zealand, no new money? Well, unlike New Zealand, when there was actually money, a bit of extra money found, that hasn't happened in Wales and Scotland. So I'm just trying to kind of understand whether you'd characterize those as strategies, and if you would, why you think they haven't perhaps had the same impact as some of these other strategies, and if you wouldn't characterize as strategies, what's missing? I guess thinking about both how we influence change outside of England, but also what we can learn from Scotland and Wales in England.
Yeah, really good question, Tom. Gets me thinking, this one. Do you know what? I wouldn't class them as strategies, and I'm not being disrespectful here, but I think the key issue for the UK is the treatment gap, especially in adult care, and the APPG has been very clear about that treatment gap, and obviously that's a UK parliamentary report. Wales have done terrific work actually around what is basically a step care model in terms of recognising the stages. And there's really good collaborative working in Wales, and obviously the health board structure lends itself much more to that than a quite adversarial historic commissioner-provider relationship does within England. So I think Wales does work collaboratively. But my issue with Wales, and there are some good things in Scotland. Scotland have got a national specification now. Obviously, there's cross-governmental conversations about this as well. So I think Wales and Scotland, I'd probably define them as doing some great groundwork from which we can push on. But the fundamental issue is the treatment gap is still there. Unless there's money, unless there are new arrangements, new clinical standards, unless we're doing something about trying to bridge the treatment gap and improve access to care, I wouldn't define them as strategies, because strategies are things that are funded, they impact on how services are provided, they've got workforce implications, and they're recognised as well. So I probably not answer that very well, Tom, but I think they're great baselines for work. But I don't see any change in the number of people who are accessing adult eating disorder care in either Scotland or Wales at the moment, and their rates are actually lower than they are in England. So strategies need to push on from the baseline work they've done to actually look to transform that care experience for people. Is that okay, Tom?
Yeah, it's a tricky one, isn't it? Because I feel like, particularly when you were saying that when they start, at least in New Zealand, there was no new money promised. That maybe your point is right, that it's the lack of push on from the initial kind of review and the recommendations.
Yeah,
it generally feels like it's taken years and years, very, very slow progress, and maybe as something that was a bit more politically engaged would see change more rapidly.
Yeah, I think testing it against successful mental health strategies, which we can do across the NHS actually. So look at perinatal, went from 15,000 women to 65,000 women because of a strategy. Look at IAPS, talking therapies, 1.1 million people accessing that in England. First episode psychosis care doubled its capacity, and CYP mental health has tripled its capacity. I think they're strategies which are tangible. And again, I don't want to be disrespectful about the really important work that's been done in a difficult financial climate, but I think there's something about pushing on from here. Thanks, Tom. Anne, shall I bring you in now?
Yeah, thanks, Stephen. That was really interesting. So in the UK, the charity sector have an important role to play in the delivery of care and support for mild to moderate eating disorders, although provision is patchy across the country. And I'm just interested in your learning from other countries, what role, if any, civil society has to play in the delivery of healthcare as system partners.
Yeah, again, really good question, Anne. I did meet with service user carer communities in each of the countries, actually, I visited. And it's probably fair to say there is a vibrant charity sector in each of the countries. And in some ways, it is filling service gaps from statutory care. But this is the point, really, that eating disorders are common conditions that many, many people impact. And if statutory services are working at small levels, then the charity sector, and as you say, civil society, does need to step in. And the charity sector does great work, and your organisation does great work. But for people trying to access care, there's a huge treatment gap there. So there's a huge role to play in. I've always been an advocate of the third sector because the third sector are agile, they can operate at lower costs than statutory services, and they can play a really good role in integrating their care with statutory services. Now, do you know what? We see that in NHS Talking Therapies now, where we've got many charitable or third sector providers who are also caregivers within that wider pathway for anxiety and depression. So I think it's a good model. I think it's a workable model, and I think we need to look at collaboration. Sweden probably has the best approaches at the moment, but Sweden's statutory services are much larger than we see in the UK. So social care is a big player within Sweden, as well as regional healthcare, and then network back into community-based organisations too.
Yeah, that's interesting. Thank you.
Thanks, Anne. Fiona?
Hi, Steve. Thank you. That was really fascinating. I guess mine is more of a reflection that with all the kind of GP collective action, we've been hit really hard, and I cover Baines, Swindon, and Wiltshire. And also, I think there's a real push to get our patients, our mental health patients, out of the acute hospitals. And I think with the development of kind of mental health hubs, we're at a real risk of really dividing our mental health and kind of physical health care. And I love the idea of these kind of joined up approaches. And I visited a CAMS team in Australia last year, so I really saw that within kind of Melbourne. So, I mean, how hopeful are you that we might end up in a position? Because I just feel like without a kind of national strategy and a national driver and push to do this, some of these things are going to be really difficult to achieve. How hopeful are you that we might be able to get to that point?
Yeah. As you get older, you get more optimistic, and it's sort of like a defense against cynicism, which comes in as you get older. And you know what? I am trying to trade on optimism on this one now. I've been in healthcare 30 odd years, but I was really wowed by what I saw in Australia because it was a proper clinical network. And clinical networks are not just about that condition, they're about the full pathway. And you know what? The NHS has got some great clinical networks, and you'd probably point to maybe cancer, orthopedics. They've got good multi-professional clinical networks. And Australia have really transformed the approach by defining eating disorders this way. It's a nightmare to think of how we might move on from where we are now, because of course NHS hospital beds are scarce commodities, and people's stay in those beds is often compromised. And the idea that you could have a designated protected space for people where you could build up skilled teams within hospitals seems a million miles away from where we are now. But you know what? These people are turning up in hospitals anyway. Service users are experiencing this late stage care. So we need to get recognition of that. The fact that eating disorders did not appear in the 10-year plan was a real disappointment. But you know what? People are now listening. So I've had maybe 3 sessions with the policy team recently, and Adrian James talked really positively and optimistically in the ministerial roundtable last week or 2 weeks ago about his moonshot. So coming back to the moonshot notion, that they want people with SMI, and eating disorders is now going to be defined within SMI, to have better life experience, better experience of care, and better outcomes. And they're looking for innovative ways that they can do this. And if we go back to the 3 shifts that we're trying to work towards in the NHS, eating disorders lends itself really well to all of them. We can do stuff digitally, we can do more stuff in the community, and we can get that clinical network working better, which is about getting more community-based care and the hospital connections working better. I'm just going to bring in Catherine, actually. I hope that was okay, Fiona, just to squeeze in one more question. Hi, Catherine. Lovely to see you again.
Thank you. I just had a couple of questions, and one I think you just touched on in terms of the moonshot. So I want to know about lived experience and whether there were an element of or a group of people that were compelled into treatment in any way, and also just from those experiences, were there any outcome measures that were used there that told you that these options were successful or which were less successful?
I mean, the compelled into treatment, I'm not sure if you're talking about use of the Mental Health Act there, or
potentially elsewhere.
I mean, this is where NHSBN data is so wonderful, actually, because you can segment what's happening in eating disorder care around use of the Mental Health Act. Obviously, it's nearly always for inpatient care. They're actually really low detention rates. I think it's the lowest of all the mental health specialties at about 25%. So I think it's used sparingly in eating disorders. But the biggest
is that elsewhere as well in your analysis?
There is more use of local detention arrangements, certainly in Australia and New Zealand. But mental health acts are much more flexible in those countries. So, for example, in Australia, you can apply for a 2-week order for someone rather than automatically detaining them for 28 days. So it's more flexible. I was really impressed by the outcome measuring within Sweden. So the Stockholm Clinic can quantify all their outcomes for the different care packages. And the same is true in Australia as well, actually. So that referencing the outcome and the recovery rates like we do in NHS Talking Therapies. I think that's eminently possible within eating disorders care. So maybe something about that moonshot for the future should be about getting some of those core disciplines that you as a data and a BI professional would like to see within this range. And of course, to provide clinical care, to provide the best care, you need to know what the outcomes are, you need to know what's working for people, and you need to listen to people as well.
Yeah, thank you.
Thanks, Catherine. Okay, I think we're nearly up on time. Joe, can I hand back to you? Thank you everyone for attending. It's been lovely to see everyone, and thanks for the great questions too. Joe, do you want to say any final words? I mean, the slides will have my email details if anyone wants to get in touch after this, but I'll hand back to you, Joe.
Yeah, no, there's been a couple of questions in the chat about getting in touch with you, Steve. So yeah, I'll share Steve's slide deck, and then happy to make the link up if anyone needs any support with that. But yeah, I just wanted to say thanks to everyone for their engagement and the really great questions that people have asked following Steve's presentation. But moreover, I just want to say thanks, Steve, for coming back and delivering this in partnership with the network. A pleasure to have you, and thanks everyone for joining. I will bring today to a close, and the recording will be made available over the next couple of days. Thank you, everyone.
Thanks, Joe. Thanks, everyone.
Thanks, Steve. Bye now. Bye.